Good evening. Good evening. Thank you for joining me tonight. My name is Thomas White. I'm the Executive Director of the Fund for Penn Medicine, and I'm very happy to be here with you tonight. For those of you just joining us for the first time for the Penn Medicine Advances series, we've been doing this for about 15 years. This is our chance to share with the community news, information about research and clinical practices at Penn Medicine, and I'm very proud of this panel we have for you tonight. 2 bits of housekeeping. This will take about an hour and will be followed by a reception in the room behind you. The panelists have agreed to stay for a little while, so feel free to introduce yourselves at that point. And second point, this is meant to be a conversation, so we left you a card and a pen. Use that to write down your questions. My colleagues and I will be collecting them during the presentation. I'll bring them up to the podium and we'll have your questions addressed by the panel at that point. So, without further ado, our moderator tonight is the chair of the Department of Genetics and the chief of the Division of Translational Medicine and Genetics, Dr. Daniel Rader.
Thanks very much, Tom. Thank you so much for coming out tonight on a cold night to hear about a topic that I think we are all very passionate about, very excited about. My colleagues up on the stage, one of whom's on the train and is going to be arriving soon. We really are excited about the topic for tonight, the concept of prevention, maintaining health, using genetics as one tool to try to do that. And we really want tonight to be kind of an open, fun, freewheeling discussion about how we can think about applying genetics in our own personal lives, in our families, in our friends, to try to help them prevent disease and maintain health. That's the theme for tonight. So, this is something I'm very passionate about myself. Some of you may know I'm an internist by training. My clinical specialty is cholesterol and cholesterol disorders. A few of you in the audience I've gotten to know through that. I've really lived a life in my own clinical work of trying to prevent disease, tackling cholesterol, aggressively reducing it to help people prevent heart disease, stroke, and the complications of atherosclerotic vascular disease. And then I really came more and more into genetics, and through that really came to appreciate the power of knowing genetic information and how that can inform risk and allow people to make real intentional decisions about trying to prevent disease that they're genetically at risk for getting. And so that's the theme for tonight. There are many, many complex aspects to that. Certainly many disease types, cancer, heart disease, Alzheimer's, many issues related to the ethics of how we apply genetics in the context of clinical care. I like to think that at Penn, we are at the forefront of really incorporating genetic information in creative ways in terms of clinical care, and we continue to do that and push the envelope in doing that. I'd like to mention a couple things in that regard. One is some of you may have heard of the Penn Medicine Biobank, a big institutional effort that we started about a decade ago that I currently co-direct with my colleague Marilyn Ritchie, who some of you may know is the inaugural Vice Dean for AI and information or something like that. I know AI is in the title. And Marilyn is just an amazing individual for those of you who have met her. And together we really have this vision of the Penn Medicine Biobank being this huge repository of information contributed in an anonymous fashion by patients in the Penn Medicine system that really help us learn more about the relationship between variation in genes and the relationship to disease. And it has already made a lot of contributions and continues to do so, and is one example of how I think we're pushing the envelope at Penn Medicine. One of the anecdotes related to genetics that I wanted to relate to you is a recent one. We all encounter patients who wrestle with genetic disorders. I'm sure many of you in family members or friends have experienced that. A couple of months ago, a team at the Vassar Center for BRCA, I'm sure many of you are familiar with that center, launched a new resource for genetic counseling conversations related to cancer risk genes and family planning. And I'm thrilled that we have a genetic counselor on our panel tonight. You'll hear from Jessica in just a little bit. So this new resource that the Vassar Center designed and released was inspired by an encounter by Dr. Kara Maxwell, an oncologist and geneticist at Penn, with a mother who at a conference for Fanconi anemia which is a rare recessive genetic bone marrow disorder that causes a number of challenges, including childhood cancer. It's inherited for a number of genes, but including BRCA1 and BRCA2. And the mother was a BRCA2 gene carrier, told Dr. Maxwell she wouldn't have changed anything about her pregnancy, knowing about Fanconi anemia, but just said, I just wish someone had told me that this was a possibility, that her child might have Fanconi anemia. And Dr. Maxwell thought to herself, if one of my patients is already dealing with the difficult news of learning they're a BRCA mutation carrier, I don't ever want them to be surprised by having a child with an even more difficult diagnosis. This is broadly related to this really complex, challenging issue of communicating genetic information to patients and families so that they can make use of that information. And again, I like to think Penn is really the leader nationally in genetic counseling education, in genetic counseling career ladder, and again, really glad to have a genetic counselor represented on our panel tonight. So with that, I think we'll begin the main event, which is hearing from our panelists. And I think the way we're going to do it is I'll briefly go to one of the panelists. I'm not going to give long introductions. They're in your programs, so you can read about them more. They're really amazing people, though, who have done great things, and you can read about that. But I'm going to let them give a little bit of a 2 to 3 minute description of the work that they do, avoiding jargon and specialized things. They've already been prompted to do that. And then I'm going to ask a few follow-up questions, and we'll move on to the next. And then we'll open things up to Q&A from the audience after that. So with that, Ronny, we're going to start with you. And Ronny Drapkin is, I think it's safe to say, one of the nation's experts in ovarian cancer. And Ronny is going to tell us a little bit about his work, and then I'll ask you a few questions. Ronny, go ahead.
Sounds good. It's wonderful to be here with you tonight. Thank you all for coming out and listening to us. This is a topic that is very near and dear to my heart. I often get asked, why do I study ovarian cancer? And what I always come back to is that when I was 16 years old, one of my best friends lost his mom to ovarian cancer. And that always sort of stuck with me. And as I went through med school and I learned more about the disease, I recall that it's a disease that presents late once, the disease has really grown beyond the confines of the ovary, and it's a challenge to treat. We don't have curative therapies. And so I was always interested in trying to understand, well, why is that? Like, why is it that we can't detect it earlier? And if we could, right, could we do something with that information? And so I trained as a pathologist. I'm a GYN pathologist. So I haven't seen any of you in my office. Let's thumbs up, right? I might have seen a piece of you, but not, So, but I was always really interested in trying to understand the disease under the microscope, right? You look at those tumor cells and you ask, how do they get there? How do they grow, right? And in work that we started now 15, 20 years ago, we were looking at individuals at high risk, right? Women who have family histories. They carry the mutations in the BRCA1 or 2 or Lynch syndrome genes, and they have a predisposition to getting ovarian cancer. And so we started looking and studying that population and realizing that we could actually do risk reduction surgery on these individuals, right? We took at the tubes and ovaries. And as we'll probably talk a little bit later, that does not come without consequences, right? Putting a 35, 40-year-old woman into menopause by removing their ovaries comes with a lot of comorbidity. And so we kept digging further into this, and we got a little bit further into understanding where these cancers come from, and we think now we actually have a better option for women. So that's how I got started. I came to Penn, I think probably tomorrow is my 10-year anniversary. Why did I come to Penn? Well, because as Dan alluded to, the Bassett Center for BRCA was started a little over 12 years ago. The Penn Ovarian Cancer Research Center was started in 2007. And so here I looked at an institution that had really made a commitment to women's cancers, to women's health. And I thought this is a place that you could see growth, you could see a future, right? They already had invested in this, they believed in this, and as Dan pointed out, they're at the cutting edge. And so that's what led me to come. I direct the Ovarian Cancer Research Center. I direct gynecological cancer research at the Bassett Center for BRCA. And it's been a wonderful 10-year journey, which I will tell you more about.
Thanks, Ronny. Can you talk a little bit about sort of the difference between sort of genetic risk factors for ovarian cancer and what I'll just say sort of non-genetic or agnostic risk factors, and how you think about overall integrated risk for ovarian cancer?
Yeah, that's a great question. So we do know that there are genetic risk factors, right? So I alluded to the BRCA1 and 2 mutations and Lynch syndrome, right? So if you carry those mutations, you have a higher risk of developing ovarian cancer in your lifetime. We also know that family history is probably the most significant risk factor. So a woman who has a first-degree relative with ovarian cancer has a 3 times higher chance or higher likelihood of getting ovarian cancer herself, even if she doesn't carry one of those specific genes. So there's definitely a strong genetic component. But to the agnostic factors that you allude to, we also know that ovarian cancer is related to what we call incessant ovulation. So what does that mean, right? We know that every month, a follicle in the ovary gets released, right, during your reproductive years, and that follicle travels in the fallopian tube, and if it meets the sperm, gets fertilized and implanted in your uterus. And that ovulatory event has a certain degree of risk for injuring the cells in the ovary, in the vicinity of the ovary. And if you ovulate incessantly, meaning month after month after month, year after year after year, you have a higher risk of getting ovarian cancer. If your menarche started early in life, if you got your period early in life and your menopause late in life and you have a long reproductive life, that's a risk factor for ovarian cancer. Anything that shortens it, late menarche, early menopause, shorter reproductive life, lowers your risk factor. Things like taking oral contraceptives, having kids, breastfeeding, all suppress ovulation and reduce your risk of ovarian cancer. So there are all these biological, physiological factors, and then there's the genetic component, right? And it's really understanding both of those in any given patient that helps us sort of figure out the risk that they may have to developing this disease.
Ronny, I believe you're credited with the concept that I think is now quite well accepted, that ovarian cancer maybe is a bit of a misnomer, and that ovarian cancer actually usually starts in the fallopian tube and then can spread to the ovary.
Yeah.
So can you talk about that, and can you talk specifically about the implications of that for prevention and for surgical interventions, for example, with regard to hysterectomy?
Yeah, absolutely. So what we now know is that these tumors start at the distal end of the fallopian tube. Right? So to avoid the jargon, I'm going to use a prop, and my good friend here has agreed to serve as my prop. Okay, so if you look at Eddie's chest, his torso as his uterus, and his arms as his fallopian tubes, and his fingers as the distal end, the farthest end of the fallopian tube. And they actually have finger-like projections here because what they have to do is catch that egg every month that gets released, make sure it gets in there. So now what we know is that these tumors actually start at the very tips of these fallopian tubes, not in the ovary, right? But they have a propensity to shed from the tube to the surface of the ovary, and they really grow well there. For reasons that we're still trying to understand why it is that the ovary itself isn't where the tumor starts, but where it loves to grow. And that's unfortunately where we detect it clinically. And once it gets to the ovary, it spreads to the rest of the abdominal cavity very quickly. So what are the implications of knowing that they start in the fallopian tube is that we can now change our risk-reducing strategy, or surgical approach to risk reduction. Instead of taking out the ovary and the tube and putting women into surgical menopause at a young age, can we just take the tube, leave the ovary in, don't put the woman into surgical menopause, and offer her the same level of risk reduction? So how are we actually asking this question? For women at high risk, so for women who have BRCA mutations, we're actually doing, there are 2 international studies now. I serve as the overall pathologist for one of them. We're enrolling 2,500 BRCA mutation carriers, and we're letting them choose between the standard risk reduction, take out both tubes and ovary, or just take out your tube. And we're following them. This is a prospective study, so we're going to sort of go on. The joke in the group has been we're either going to get an answer in 2036 or we're going to run out of money. But one way or the other, we're going to try to get this done. And the idea is, if we take out the tube, can we afford them the same level, non-inferior risk reductions? That's how we're doing it in the high-risk population. In the average population, so this is all women at average risk, how is this changing the way we practice? We're now doing what's called opportunistic salpingectomy, right? Opportunistically taking out the fallopian tube. Under what scenario would that happen? A woman who might have fibroids and is in pain or is causing bleeding or affecting fertility might choose to have a hysterectomy. It used to be that if we took out the uterus, we left the tubes and ovaries behind, right? Do no harm. Now, what's happening is that people are saying, well, could we just take out the tubes with that uterus in any case that's not cancer? So prolapse, fibroids, things like that. I can tell you that the rate of that adoption of opportunistic salpingectomy went from 6% in 2010 to over almost 80% in Canada and the United States as of last year. So it's really, in the average risk population, really taken off. And it's hopefully going to reduce the overall burden of disease for this cancer. So that's what we're very excited about in terms of how we're translating that information to giving women better choices for risk reduction.
And you're being modest, but the work of you and your colleagues really contributed majorly to that. My final question is, so Ronny, as you know, and I think much of our audience knows, the Vassar Center has initiated this whole program about cancer interception. And I just want to say, I love that term. I know our title tonight is prevention, which I love too, but I love interception, and it's not just because the Super Bowl's coming up, but the concept of like going out there and intercepting that cancer that may have just started, but you don't even know it yet. But so anyway, it's a great term. Can you just speak to cancer interception with regard to ovarian cancer?
Yeah, I need your hand again. No, you can sit down. Okay, so if these tumors start at the different tips of the fallopian tube, right, before they shed to the ovary and grow there, as I described, right, can we intercept them? Can we eradicate those early cells in a woman who doesn't even know she has it, right? This is what we call a hidden or occult cancer, has no other symptoms of disease. Can we give her something that wipes out the fingertips, essentially, of the fallopian tube where the lesions are, and reset her clock, right? Move her back in time, so to speak, so that she doesn't have to necessarily deal with this cancer at whatever age it would have been. We've saved her some time. And so how do you do that? You need to know, if you're going to intercept, you need to know what to intercept, right? So in football, we're trying to catch the football. But here, right, what are we intercepting? And so we argued a few years ago that we need to do a real sort of panoramic understanding of these precursors in the fallopian tube. And we recently published what we call a pre-cancer atlas. Think of Britannica Encyclopedia, right? Everything you wanted to know about these precursors in the tube. Because if we understand the alterations that happen there, we could figure out, are there markers that could be used for early detection? Are there markers that we could target with therapies to wipe out these early lesions in an otherwise healthy woman who doesn't have to actually struggle with advanced disease? And that's the concept of interception. We're really excited, just like Dan is, about actually trying to deploy that in this setting so that we can give women longer life and better life.
Thank you, Ronny. Thank you for your great work. I'm going to turn Jessica, stay on the cancer theme for now. So Jessica, as I said, is a genetic counselor, experienced counselor who focuses on cancer at Penn. And Jessica, I'll give you a few minutes to talk about your work, and then I'll ask you a few questions.
Sure, sounds great, thank you. And I'm so pleased to be here, and I'd also like to borrow you for all of my counseling sessions from now on as a source of human visualization. My work as a genetic counselor, I'm in the Penn Medicine cancer risk evaluation programs. And like Dr. Drapkin, I was drawn here to the University of Pennsylvania around 2012 with the inception of the Vassar Center for BRCA, which is really a center of excellence for families affected by hereditary breast and ovarian cancer, thanks in part to a transformational gift from Mindy and John Gray that allowed the establishment of this. And then over the last 10 or so years, due to my area of expertise, also be focusing more on gastrointestinal cancer risk, so families affected by colorectal cancer, pancreatic, and other types of GI cancers. I've had the great opportunity through the generous gifts from Julie and Jason Borelli and Jeffrey and Cynthia King. We've developed the Penn Medicine Lynch syndrome program, which is dedicated to families affected by Lynch syndrome, one of the most common, if not the most common, source of hereditary colorectal cancer risk that perhaps many of you in this audience haven't even heard about. And so that's really our mission and our goal. And my work with the Lynch syndrome program as the associate director is how do we get education and advocacy and clinical care excellence here at Penn Medicine, but also into the broader medical community and into the public. And so my work really, it centers on clinical care, research related to these issues, and also education and advocacy specifically for people and families affected by hereditary cancer risk, as well as polyposis, which is just a fancy term meaning lots of polyps in the GI tract that have the potential to become cancerous if not appropriately intervened upon. And so as a cancer genetic counselor in my clinical work, I speak with people on a daily basis who have a personal or a family history of cancer, and they want to understand, why is this happening to my family or to me over and over again? And beyond the why, what can we do about it? What can we do to either help promote early detection of cancer or prevention of cancer in the first place? And so my colleagues and I, we provide personalized cancer risk assessments. We also talk about options for genetic testing, the pros and cons of those options, to really highlight what strategies can we use to better assess who in the family is or is not at risk, and how can we promote those screenings and other early detection methods. And then, as I mentioned, for my roles in the Vassar Center for BRCA and the Lynch Syndrome program, we also host yearly symposia where we're trying to get the word out on what's the cutting edge research, what are the advancements in clinical care, and what are other efforts that we want everyone who's helping care for families with Lynch syndrome or with BRCA to know about. And that really harkens to tonight's focus on preventing disease. That's the same message we work to deliver through our program. So I'm really thrilled to be here tonight.
Thank you, Jessica. Thanks for all your great work. Can we just talk a little bit about the issue of like who should be tested for genetic risk of cancer? Of course, the classic is family history, but genetic testing is so widely available now, and we'll talk a little bit about insurance coverage, but it's pretty good. Where are things going in terms of recommendations to just, should I be tested for BRCA, BA, or genetic risk of cancer more broadly, and how do you answer that question?
Yeah. And as you're alluding to, genetic testing has become more readily accessible and less expensive than ever before. Ideally, we always want to start out with the most informative person in the family. And so if we're worried about cancer in a family, and we want to know, is there a genetic cause that we can identify of this cancer, it's most informative to actually test the person who's manifested that cancer first. And so whenever possible, we try to approach a family in that way. If someone comes in and it's their parent or their sibling, as a counselor, I work with them to understand the family dynamics, the family structure. Is this something that might be feasible in this family to really offer testing to the most informative relative first? And sometimes it's not possible, and sometimes we're left with the person who maybe is not the most informative, but the one who's most motivated in the family. And there's certain national criteria that we use to help us better assess when are cancers more likely to be hereditary versus when are they more likely to be due to aging, environment, lifestyle factors. And ultimately these criteria, they typically look for 3 clues to hereditary cancer risk. So when I draw out a family tree, as I speak to someone, who are your aunts, uncles, cousins, brothers, sisters, I'm looking at age, number, and pattern. Who is diagnosed at a younger than average age for that type of cancer, like breast or colorectal cancers under age 50? When is there a number of cancers, either from generation to generation in the family, or a number of separate cancers? I don't mean a metastatic spread, but separate, unique cancers in a single individual. And then also certain patterns of cancer types that we can recognize, whether breast and ovarian for BRCA, or colon and endometrial or uterine for Lynch syndrome. And so these are some of the criteria that we use, as well as certain rare cancers like ovarian or pancreatic, given their association with genetic risks. Any individuals with these cancers now meet criteria for testing.
In genetics, we talk a lot about actionability. Can you just say a few words about the concept of actionability of variants that are found on genetic testing? And maybe in that context, can you talk a little bit more about Lynch syndrome in particular? And it's so actionable in a sense if you found to have a variant with Lynch syndrome. Why don't you say a few words?
I'm so passionate about this topic, and this is really what's drawn me to caring not only for people in the hereditary cancer clinic, but Lynch syndrome in particular. We know that Lynch syndrome affects 1 out of every 279 individuals. That's a lot of people, contributing to about 5 to 10% of colorectal cancers. And yet, what's causing this colorectal cancer risk in Lynch syndrome is that in the average person, a small growth or a polyp in the colon, it might take 10 years or 15 years to grow into a cancer. So average risk people start at 45, get a colonoscopy every 10 years, but in a person with Lynch syndrome, there's an accelerated, what we call adenoma to neoplasm pathway. That polyp becomes cancer faster, maybe 3 years. And so in people with Lynch syndrome, when we appropriately identify that, we start colonoscopies depending on the particular gene, because there are genetic differences related to the 5 genes that can cause Lynch syndrome. Sometimes we start colonoscopies between 20 to 25, sometimes between ages 30 to 35, and we're doing those procedures every single year. Now, nobody likes to prep for a colonoscopy, GI joke, but it is so incredibly powerful in our ability to get those polyps out. We've just prevented a colorectal cancer.
Yeah, so starting earlier when you know you have a variant is really important. So I'm sure there are going to be more questions for Jessica in the Q&A. In fact, she may get the most questions of anyone, but I think we'll move on. Turn to Eddie Lee. So Eddie is really one of the world's experts in Alzheimer's disease, co-director of the Institute on Aging at Penn. Eddie's going to say a few words about his work, and then I'm going to ask you a few questions.
Great.
Eddie?
So nice to meet you, everybody. My name is Eddie Lee. I've been at Penn since '97, so I've been there for quite some time. And I'm a neuropathologist and a scientist. And wear many different hats, including directing our brain bank. And so this has been over 40 years collecting different brain donations for different neurodegenerative diseases. So that includes Alzheimer's disease, Parkinson's disease, and other rare dementias, including diseases like frontotemporal dementia, which Bruce Willis, you may have heard, is going through right now. And my work, I like to think about genetics and the brain, because if we have the genetics, we're kind of talking about what's causing disease. And I'm able to look at the brain under a microscope and figure out what's the consequence, what's the result of these genetics. So just to give you a few examples, part of our research is interested in rare or even ultra-rare genetic cases. And so a woman called me several years ago saying, my son developed dementia and nobody knows what this is. Can you look at his brain? He passed away, and try to give us some answers. And so we received that brain donation. A couple years later, her second child had the same disease, and then a couple years later, her third child. So all 3 of her children died of this disease. And from this, we were able to figure out what is the genetic mutation that's affecting their family, and what's going on in the brain. And in the brain, they were building up these proteins called tau, and that's the same protein we see in Alzheimer's disease. And so it's a genetic cause that's decimated this family, but has links to Alzheimer's disease. And now that we figured this out, the family, I remember a few years in, they were saying, do you have any answers? So-and-so wants to get married, or this person wants to have a child, and they need answers. And thankfully, we're able to give them answers. My hope is that this is the last generation that sees this disease, because we could screen and do pre-implantation genetics to prevent this disease from going on. But this is ultra rare, so it affects 4 families in the world. I think we have 3 people affected who have this, although the next generation, we know that the gene has been passed on, and we hope to stop it there. But it has implications for Alzheimer's disease because it has the same protein. So based on that gene, we're now developing drugs or drug-like molecules that we're hoping to target this gene so that we could treat not just this family, but everybody with Alzheimer's disease. So that's an example of a very ultra-rare genetic cause of disease. We're also interested in the very common genetics. So there's a gene called ApoE, where there are people in this room who have the variant that increases your risk for Alzheimer's disease. And so understanding how that genetic variant affects your brain pathology, the stuff that's going on in your brain, and how it affects new therapies is another big interest of ours, because that's by far and away the largest genetic risk factor we have for these diseases. So again, it's the pairing of the genetics and the tissue that's proven to be very powerful in giving us clues on what's causing dementia.
So sticking to the theme of genetics and prevention. So we just talked about actionability and cancer, cardiovascular disease, which we'll talk about in a little bit when Kieran gets here. Very actionable in terms of prevention. I think one of the issues with Alzheimer's has traditionally been, well, if I know I'm at genetic risk, if I know I have ApoE4, 1 or 2 alleles, what am I going to do anyway?
Exactly.
So can you speak to, where you see the field is now and where it's going with regard to trying to prevent Alzheimer's?
So last year was kind of a watershed year for Alzheimer's disease. 2 drugs were FDA approved. And these are the first drugs that actually change what's going on in your brain on a mechanistic level. So it's clearing these amyloid proteins from the brain. I'd say before this, the reason to get genetic testing was a very personal decision, and you can or you could choose not to. Now that there's something that you could do to treat people, I think it's going to become more important to know what your personal risk is, especially if you have a strong family history. On top of that, these new drugs actually have side effects, and they can be serious in some individuals, and that relates to your genetic risks. So if you have an ApoE4 genotype, you're more likely to develop these side effects. And so we're actively studying that. We're following, so Penn was one of the first places to start these new drugs. We've treated hundreds of people, but we're studying them and their genetics and trying to figure out why do certain people develop the side effects, why do certain people not. So I think now that we have targeted therapies, there's more of a reason to get genetic testing. I'll say the other thing, so Penn has active research into disclosure, and so what happens when people get their genetic scores back. And it's interesting, if we do it in a controlled environment where given proper counseling, it's actually pretty safe and doesn't cause that much emotional distress. If anything, people understand their risk more, but it doesn't really change your behaviors much. It kind of just gives you that knowledge. So I think that if done in the proper setting, these genetic disclosures can be helpful. And I think as we develop more therapies, it'll be more important.
I know you work.
And the prevention. The prevention part. So the very interesting thing in one of the trials is that they chose people who had either early dementia or something called mild cognitive impairment. That means you have, when we test you, your cognitive ability is a little bit decreased, but that's not enough to affect your daily life. But when patients finally got the drug in the trial, some had mild cognitive impairment, some were early, some were moderate dementia. The moderate dementia patients actually didn't improve at all. The early improved some. The mild cognitive impairment patients did the best. So now what we're doing is we're going backwards. So we have blood tests plus a genetic test where we could tell if the pathology is building up in your brain before you have any symptoms, before you have any cognitive problems. And the hope is if we treat you then, that you prevent the disease from even starting.
And I would say there's a little bit of a parallel to Lynch in that if you know you're at high genetic risk, then maybe the next step is some sort of imaging procedure to look for the presence of plaque even before you've had overt symptoms, as you said.
Absolutely. It's the same paradigm. We always say we're about 15 years behind cancer, so we learn a lot from our cancer colleagues, but we're using the same roadmap.
And then finally, I just want to ask you about Parkinson's disease, also of great interest to you, great interest to Penn. Our colleague Alice Chen-Plotkin just got a recent big grant. Can you just speak to the progress in Parkinson's in terms of treatment and also prevention?
Yes. So many of the same types of drugs that we're testing in Alzheimer's, we're also testing in Parkinson's disease. So these are these biologics that could either shut off the gene or immunotherapies to target the proteins. So that's still ongoing. We don't know if those will work. But on the diagnostic side, we're developing new diagnostics. So skin biopsies or spinal fluid taps are able to tell us what's going on in your brain now and give us those diagnoses ahead of time. And again, I think there's this yin and yang where as you get better diagnostic ability, the therapies kind of co-evolve along with that. You kind of need them both to develop at the same time.
I think it's fair to say that the next decade is going to be incredibly exciting in the neurodegeneration field.
I think it's going to be amazing.
Yeah, absolutely. Okay, I'm sure we'll have more questions, Eddie, but I'm going to turn to Sarah Tishkoff. Dr. Tishkoff is a member of the National Academy of Sciences. She's currently president of the American Society of Human Genetics. And she's also director of a really novel center at Penn, the Center for Global Genomics and Health Equity that she founded several years ago. Dr. Tishkoff, I'll let her tell you about herself, but she's world known for her work in genomic diversity and how that impacts on both disease and phenotype, but also on health disparities. So, Sarah?
Well, thank you so much, Dan, for the introduction. I'm so excited to be here tonight. And I thought I'd start by just telling you a little bit about my own research and what we do. So we use a very interdisciplinary approach where we integrate fieldwork in Africa with genomic analyses to better understand human evolutionary history, how we've adapted to different environments and diets during evolution, and also the genetic and environmental factors that play a role mainly in cardiometabolic, skin, and immune-related traits and diseases. Now, why Africa? So one, it's the place where all modern humans evolved about 300,000 years ago. It has the most genetic diversity in the entire world, and yet it's greatly underrepresented in human genetic studies, which has led to health inequalities. So because of my passion to understand the causes and cures for health disparities, I founded the Penn Center for Global Genomics and Health Equity in early 2020. And what we're trying to do to tackle these issues is to promote research, genomics research at Penn in this area, education, policy work, and then ultimately practice. Now, one of the other motivations for this is something I actually was taught when I was a first-year student in grad school at Yale, which is that most diseases that have a genetic basis will show a difference in prevalence across different ethnic groups around the world. So I think many of you here are probably familiar with some examples of diseases that are caused by a mutation in a single gene that differ in prevalence. So Tay-Sachs, for example, is more common in people of Ashkenazi Jewish ancestry. Sickle cell disease is more common in people of African, mainly West African ancestry. And cystic fibrosis is more common in people of European ancestry. But we also see differences in the prevalence of common disorders that we call complex disorders because they're caused by many genes and environment together, such as hypertension and kidney disease, which is more prevalent in people of African ancestry in the US, adult onset diabetes, which is more common in people of Native American ancestry in the US. Now, undoubtedly, there are major social, demographic, nutritional, other lifestyle risk factors, right, that are playing major contributions to those health disparities. But we think there are likely to also be underlying genetic risk factors, and I think one of the biggest challenges right now in our time is to distinguish between the genetic and the environmental factors that are playing a role in risk for disease. So the problem is that there is a major bias towards inclusion of Europeans in genetic studies of disease risk. So just to give you an idea, about 80% of participants are of European ancestry, about 10% are of Asian ancestry, 2% African ancestry, 1% Hispanic ancestry, and less than 1% everybody else. That is a huge problem. I think it is going to majorly exacerbate health inequalities, and it has implications for the clinic. Because right now, people in the clinic are actually starting to apply something we call polygenic risk scores, or genetic risk scores. For example, for risk for heart disease. And these are calculated based on these genomic studies that are mainly done in Europeans. And what people have shown is that when you calculate these scores in a patient who is not of European ancestry, they do not work. They will actually give you wrong information. So for that reason, I think we really have to be more inclusive in human genetic studies.
Thank you, Sarah. I just want to call out Bogdan Pastanuik, a new member of the genetics department, who's really a leader in polygenic risk scores and addressing the problems that Dr. Tishkoff just described. So Bogdan, glad you could make it tonight. Sarah, can you address this issue of the so-called variants of unknown significance and how that problem is really exacerbated by the disparities in terms of the genetic information that's available? And then if Jessica wants to chime in, she can. Yeah, go ahead.
So one of the problems is that, let's say that a patient comes in and you're going to sequence the genome. You want to try to figure out, they have a rare disorder, something like that. You can't figure out what it is. So there have been databases that have been generated to determine that list what the variants are that are pathogenic. And one of the criteria for determining if a variant of unknown significance is pathogenic is how common it is. So maybe it's common in Europeans, and so they knock it off the list and they say it's not, or actually maybe it's rare. Say it's rare in Europeans, so they say yes, it's pathogenic. But you look at other populations and you find out that no, it actually is common. That's one issue. But the second is, let's talk about even BRCA, right, or cystic fibrosis. Much of the work has been biased towards people, mainly of European ancestry, and what we're finding is that it's really problematic. I'm sure you could say more about diagnostics, right? Because there are so many other variants that are there, but they just haven't been characterized yet. So it's really critically important.
Please, please.
I think you're so spot on. Because what we're noticing now, we're looking for biomarkers of early detection, right? Something you can look for in the blood. And we found some really interesting ones. And what we keep stumbling on is realizing that most of the data that we've collected are from individuals of European descent. And to think that that marker is going to work across the broader population, which is much more heterogeneous, I think is a grave mistake. We recently stumbled upon this because we were looking at a particular marker. Initial data looked like, oh, it's really good at detecting cancer, not in normal. And we thought this would be wonderful. We got a cohort of samples from black patients, and the marker is not nearly as high as it is in the white population, right? And so if you went into that to the general public, you might actually misdiagnose or mistreat people because of this idea that it's going to be the same when it clearly isn't.
Yeah. And Sarah, can you say a word about the impact the center is having locally here in the Philadelphia region, and maybe a word about the African Immigrant Project?
Oh, sure.
Yeah.
So we do several things at the center. So one is that we give away pilot grant money to researchers at Penn who are focusing on studies that are looking at genetic and environmental factors that are playing a role in health disparities. Second thing is education. So we started the Health Equity Scholars postdoctoral program. We also started for a unique program with Lincoln University, which is the first historically black undergraduate college in the US. We are training undergrads in the summer. And we want to train the next generation of scholars who are going to work on studying health disparities. And then we do seminars and symposia. But the other thing that we do, and this was actually motivated because we started the center, my first hire staff was like January 2020. March of 2020, COVID comes, we're shut down, at least at the university. We're all working at home. What is one of the biggest health disparities that we're seeing? It's risk for COVID infection and death from COVID. So we immediately applied for funding from the Department of Health in Pennsylvania, together with Dan Rader and other faculty are involved, to study risk factors for COVID-19 in the Philadelphia community. So that led us to do a lot of outreach to members of the community who are working both with the African American community, but also specifically with African immigrants, because there can be very different issues actually in that population. And when we do this research, we give back some information about health status, and actually with Dan, we're giving information about lipids, because I feel like it is extremely important that they need to benefit. It has to be a two-way thing. So on the one hand, we are benefiting, and everybody in this room from the knowledge we're gaining, but they have to benefit as well. And so I also think it really helps in terms of the community relations between Penn and our neighbors.
Great. I think we'll turn to some of the questions, and I think if you still have a question, you can raise your card, and we're happy to come pick it up. So as I predicted, Jessica has a lot of questions. So Jessica, I'm going to start with you. And the first is there a genetic link between breast cancer and Lynch syndrome?
That's a great question. And that has been a subject of debate over the years since Lynch syndrome has been identified and studied. When Dr. Henry Lynch first described the condition, he thought that yes, there was a strong link between the two. But it's important to note in the early days of identifying any genetic disease, who are we studying? We're studying the families that are most affected. So we're studying the families that have the most cancer. And so as time goes on and we continue to study diseases and we identify more and more families that have diseases like breast cancer or Lynch syndrome, we learn more about it, we start to learn that maybe some of the original risks that were reported aren't what we thought they were. And so now that genetic testing has become so much more accessible and more people are being tested, when we look at some very large data sets of people tested for Lynch syndrome, and we look at who in these families with Lynch syndrome do or do not have breast cancer, keep in mind that's an incredibly common disease. 1 in 8 women will be affected with breast cancer by age 80. So you really have to sort out what is just the average risk common disease, what is actually attributable to Lynch syndrome. So we don't think that there's a significantly high risk just due to Lynch.
Jessica, I think it's fair to say that a lot of primary care physicians still aren't quite at the stage where, if a patient comes in and says, I have a family history of colon cancer, breast cancer, they're quite comfortable. So I'd love, this is related to one of the questions, for you to describe to the, to this audience, if you feel like you would like to be tested for genetic risk of anything, cancer, what should you do?
That's a good question. I think primary care is a great place to start. We get a lot of referrals from our primary care and gynecology physicians who have such a breadth of knowledge. But that's what we in these various specialized genetics clinics are here for. If people have a family history of cancer, I often like to say, I'm not here just to send people to the lab to give a blood test. I'm here to look at the family history and help that person understand what's the probability that the cancer in their family is just more age-related, environmental, or when do we think that the concern is significantly high enough for a hereditary condition that it may be worthwhile doing testing. So I'd say find a genetic counselor or talk to your doctor about a referral.
Yep. Ronny, a question. You mentioned ovarian cancer is often diagnosed at advanced stages. You've touched on this, but the question is Penn researching ways to detect it sooner?
Yeah, absolutely. So in addition to the prevention stuff we talked about in terms of surgical strategies, we're very much interested in trying to find tools to help us detect it earlier for the same reasons, right? If you find it earlier, you have an opportunity to catch the disease. The data behind it, just to give you some numbers, right? If you catch ovarian cancer in what we call stage 1, the 5-year survival rate is over 90%. Unfortunately, the majority of our patients get diagnosed at stage 3 or 4, and the 5-year survival rate hovers around 30, and it hasn't changed much in years. So of course, if we could find it earlier, right? Having the understanding that these are coming from the fallopian tube now, we have this encyclopedia of information on the tube. Now we have the opportunity to start asking, what are the unique things that are secreted, for instance, by tubal cells that might be detectable in the bloodstream? Or could we use for imaging modalities to detect these early lesions in the fingertips of our tubes?
If I could comment on your biomarker detection and just make an editorial comment that relates back to my comment about the Penn Medicine Biobank. So one of the great advantages of this is that the biobank stores also sort of plasma, so blood that we obtain with the consent of the individual, and we can go back and retrieve those samples from the freezer. And for example, in a study that I want to do with you, Ronny, the people who didn't have ovarian cancer at the time they enrolled in the biobank, but that subset of individuals who went on to develop ovarian cancer later, which we know from their chart, we can go back and then test the blood and look for biomarkers that were present prior to the actual diagnosis. So that's the sort of thing I know you're working on, and that's the sort of thing that the biobank that I mentioned can help us do. So, Eddie, excuse me for a second. What evaluations do you suggest that children who have a parent with Alzheimer's should have?
It depends how old the child is. So if we're talking about adult children, I think currently you want to get a good family history. You kind of want to understand what your perceived risk is. And it depends how strong that family history is. And again, I'm dealing with both common diseases like Alzheimer's disease, where a significant proportion of people over 65 will develop that disease, versus rare conditions where you could get an obvious every generation affected by this disease. And so depending on that, that will guide what kind of testing you might do. I think it's important to talk to your physicians, your primary care physicians, so that they know your family history. I think the treatments right now, again, are actually very time-consuming, and there are a lot of side effects. So the treatments right now is an infusion every 2 weeks or every month, continuously. And so that's a high burden. I do think the next few years we're going to change that. It'll become subcutaneous injections and much easier ways to do this. And as the therapies evolve, what's going to happen, my prediction is within 5 to 10 years, we already have blood tests that could tell you whether or not you have amyloid in the brain, right? Which is amazing. You could draw a tube of blood, and we could tell you where you're developing the pathology in the brain, even before you have any symptoms. And so I think it'll be almost like a cholesterol test. Once you hit a certain age, people are going to get a blood draw, and you're going to measure this, determine your risk for Alzheimer's disease, and that'll dictate whether you go down a treatment path or not.
Thank you. Ronny, we have a question about pap smear. Do you recommend pap smear after menopause? But I want to broaden that, and we haven't talked about cervical cancer, but it seems to me cervical cancer is one of those cancers that we ought to be able to abolish, like smallpox, between the HPV vaccine and pap smears, including self-done pap smears or sample collection. So can you just speak to that issue?
Yeah, I mean, I think cervical cancer screening is probably the best example of prevention that we have. I mean, you know, it's right in there with colonoscopy and other strategies that have been shown to reduce mortality, which is amazing. And we actually use cervical cancer as a great example, right? Because we know when a woman does a pap smear that as a pathologist, I can tell if those lesions are worrisome, I need to follow up with something, or if they're likely not to necessarily progress, right? And so you have these, you know, I always keep talking to my colleagues about what are the precursors that I need to worry about, right? How do I tell this weird looking cell is a problem or it's not really a problem, right? In cervical cancer, we've been able to do that. We've been able to stratify into sort of buckets, you know, SIN1, SIN2, and SIN3, and we can say, okay, this one is probably gonna regress on its own. This one, we need to do some more here to prevent the cancer from growing. And so we're using that model as to ask the same question of what's happening in the fallopian tube, right? Are all precursors created equal? Are they all destined to become a cancer? We need to know that, right? So that we can counsel our clinical colleagues and our patients. The interesting thing about the pap smear, right, which people are starting to do now, is because the pap smears is biopsying the cervix, which is much closer, it's in the reproductive tract. Is there a signal from the fallopian tube that is being shed and could be detectable in the pap smear, right? So what we call tissue proximal sampling, right? Getting closer to the source. And there's a lot of interest about using pap smear cytology and specimens to look for things that might be happening higher up in the reproductive tract as a signal for cancer. So a lot of activity in that space.
Great. So we have several questions about the impact of food and alcohol on cancer risk and cardiovascular disease, a really hot topic. And it also relates to a very simple question we have that I'm going to ask Sarah to address, and then I want to come back to the food and diet issue. Sarah, can you address the question simply without jargon? What is epigenetics?
A hard one. But see, the problem is, Dan, that there's too many definitions. So I'm just going to give you maybe more of a common idea of that. Would be modifications to DNA that impact whether a gene is turned on or off, and those modifications can be the result of environmental factors. So it's a way that you can actually truly have genetic by environmental interactions. Is that what you were, did I pass that?
That sounds great. That was great. So basically there's the coded genome that we all inherit. Sometimes that can be modified. We're not talking about that today. It's related to cancer. But then the genes that are being expressed are affected by everything we're exposed to in our environment. And that's through the epigenome and through modifications at the DNA that are not inherited, but due to environmental exposure. And one of the key ones is diet and other things we drink and eat. Ronny, can I ask you maybe to just address the recent discussion in the lay press around alcohol and cancer? Could you just give us your take on that?
Yeah, well, so my overall take on this is that moderation, right? Everything in moderation. But there is an association with, cancers, all kinds of cancers. We used to think that it was just sort of your GI tract, right? Where the alcohol, right? Your esophagus and stomach and so on. But it actually turns out that it is a risk factor for other kinds of cancers. And I sort of think of this as most things, right? That in moderation, there's probably early evidence suggesting there's a benefit. In excess, right? We know that there's going to be a risk. I don't know if it's going to lead to warnings, labels on your favorite booze that you purchase. We'll see. But I do think that it's worth being aware of. And I know that during the pandemic, there was a huge spike in alcohol consumption as people were home, and there was a whiskey boom, and all sorts of stuff happened during the pandemic. And those things can lead down troubling paths, and you have to sort of moderate.
Great. Can we stay in this theme for a second? Eddie, alcohol and Alzheimer's. Rapid question.
I don't know if there's a ton there. There's stuff about the gut and Parkinson's disease. And so Parkinson's disease patients often have constipation or GI motility issues. And the protein there is called alpha-synuclein that builds up in the brain. And it turns out that we could see this protein actually building up in the gut. And so it's thought that maybe that goes from the gut into the brain and spreading through the brain. And we can do this in mice. So if we start the protein misfolding in the gut and we watch these mice, it explodes into the brain and the brain starts to degenerate. So it's pretty remarkable. So there's a strong gut-brain axis for Parkinson's disease. I'll say that axis is not as strong in Alzheimer's disease, but we're still working that out. And the other general theme that's coming out is that just inflammation in general is just not good for your brain. And so that's, any infection, all these things are just kind of creating this environment that's slowly damaging your brain and is thought to contribute.
Yeah. And I just want to say briefly, alcohol and heart disease. My take on that would be you should not have your daily glass of wine to prevent heart disease. That concept is no longer valid. I don't think in moderation, a little like I don't think alcohol is necessarily a huge problem, but beyond moderation, and the problem is people are different in that way, alcohol is most definitely an issue in terms of heart disease risk. So that would be my take. The other thing I want to mention is that we had several questions about diet and inflammation and personalized responses to diet, and this concept of nutrigenomics, the fact that just like pharmacogenetics, your genes affect your response to drugs. We aren't even talking about that tonight, but that's a huge topic. Nutrigenomics, your genes determine your response to diet. And ultimately, we think we'll get to the point where we can use genetic information to tailor our dietary recommendations to people a little bit more in a personalized way, as opposed to one size fits all. We're not there, but there's a lot of work going on in that space, and I think it's very exciting. So Dr. Musunuru, I think, got stuck on the train, right? Yeah. So unfortunately, he does like amazing work, and I'm not going to try to describe it to you, except to say he is one of the world's leaders in therapeutic genome editing, going in with CRISPR and changing a part of the DNA in order to improve health. One approach he's doing that is in rare metabolic disease in the liver, where a single mutated piece of DNA or base of DNA, they can go in now and change that in the liver and correct that disease, which is often a fatal metabolic disease in a young child. It's just amazing. And really, Dr. Musunuru, with a couple of his colleagues at Penn and Chop, are really in the forefront of that. But the other approach that he's taken that I know he would have talked about if he were here, relates to one of our questions, which is there are certain genes in the liver, some of you have heard of PCSK9, that we don't need anymore, and he is working to shut it off in the liver. Cholesterol levels go down by 100 points, and the idea is that that would be lifetime protection from the effects of cholesterol and reducing risk of heart disease. And it's happening, it works. And the idea is, he likes to use the term a vaccine for heart disease, that a single shot at one point in time in life permanently reduces cholesterol and protects against heart disease. And I think what's interesting about that is that obviously it has a lot of advantages instead of taking your pill every day or giving yourself a shot every 2 weeks. But it's also, in theory, ultimately much more amenable to the rest of the world. especially
can I
places
actually
where
follow up?
getting drugs that have to be given every 2 weeks are very difficult, but a one-time shot could be immensely transformational. Sarah, do you want to comment on that?
Yeah, what I wanted to follow up in that particular example is that is a great example, because that gene, that target, that therapeutic target would never have been known without studies of diverse populations.
Yep.
So what happened was, it was actually an African American family where everybody in the family had exceptionally low LDL. And they found this mutation in this gene, PCKS9. And then they looked at a larger sample of people of African ancestry, found an association with that gene. That identified it as the target. Regeneron developed a therapeutic that is super effective in everyone. So everybody benefits from the knowledge that we gain from studying diverse populations.
So that leads me to one of the questions we got, which one of you can volunteer for. Realistically, what is the prognosis for getting a vaccine for BRCA carriers, so women don't have to have, for example, mastectomies as the only intervention? Jessica, you want to start with that?
I will start, and when I get into deep water, I'll pass it off to Dr. Drapkin. But I'm really thrilled to say that through the work being done at Penn Medicine, we actually have 2 ongoing vaccine studies that are geared to prevent cancer development. One in individuals with BRCA-related cancers, and then also there is another that is being developed for individuals with Lynch syndrome to prevent Lynch-related cancers as well. And the vaccines for individuals with BRCA, pathogenic variants, this is already being trialed at Penn Medicine and in other sites in humans already. And from here, I'll pass it off to Dr. Drapkin to see if that
was great. Nailed it.
You want to add anything, Ronny?
I think it's a fascinating area. We're actually working with Drew Weissman now on trying to develop a vaccine for BRCA carriers and women at risk, targeting part of our genome that doesn't usually get expressed, right? So if you look at our table here, right, as a pizza pie, a very, very small slice of pizza is actually turned into the proteins that we talk about. The rest of it is what we used to call junk DNA. It actually turns out that the junk DNA gets expressed and activated in early cancer, and because the immune system never sort of sees it because it's shut down, it might actually be a really great vaccine target. And so we're exploring that idea with Drew and trying to make an RNA vaccine on the heels of obviously the success that he had with the COVID vaccine.
That's great. 2 more questions and then we're going to move on. The one question, of course, was about AI and how we think about the use of AI in the context of what we're talking about. And in the interest of time, I'm going to take a crack at that. And if anybody else has a comment about AI in their own work, I'm going to invite you to comment. So, I mentioned my colleague Marilyn Ritchie is sort of chief of AI for Penn Medicine. And there's a lot of work going on at Penn related to the application of AI to health. And I'll give you one example that maybe I'm a little more knowledgeable about. And that is that even at Penn, we think there are quite a lot of people who have conditions who haven't been diagnosed, even at Penn. And that's because it's hard. Diagnosis is often hard. But nowadays, what we can do, and we're starting to do now with several conditions, I'll give you one example, is if you take a bunch of people who you know have that condition, and you train an AI model on all the features of that, and then you say that to that model, okay, now look at the entire Penn Medicine data, and find or flag other people who look based on the model like they might have that condition, but haven't yet been diagnosed with that. And then you can go out and look at those individuals or potentially evaluate them further, let their doctor know that they've been flagged, a way of identifying people who might have a treatable disease. One of the conditions we're doing it for is a genetic condition. Some of you have heard of it. It's called amyloidosis, TTR amyloidosis, and that is the protein deposits in the heart and the nerves and causes neuropathy and cardiomyopathy. And it's underdiagnosed, and yet it has tremendous therapies. So we have very good therapies for this, but we're not making the diagnosis nationally and internationally as much as we should. This is one way to try to identify those people and then flag them for diagnosis and further therapy. So any other comments about AI before we move on? I'm going to move to the last question, which I like and really helps integrate some of what we've been talking about tonight. And to what extent does genetics play in type 1 diabetes? And the reason I love that question is it actually is one of the areas that I think at Penn right now, we're integrating a lot of the different things that are being done in a way that is super exciting. So type 1 diabetes, yes, mostly in kids, but adults do get diagnosed with type 1 diabetes as well. And if you are found to have antibodies that predict progression of type 1 diabetes, there's actually an approved drug, an antibody that can be given to prevent progression to type 1 diabetes. The problem is figuring out who those people are. So at Penn, we have sort of an integrated program where we're using genetics and polygenic risk scores, like we were talking about earlier, to look at genetic risk. Type 1 diabetes is very genetically affected. And then we have, many of you may know, we have this amazing immune health program that is really being designed to look very carefully at the blood cells and the immune signature of those blood cells and the relationship especially to autoimmune disease. And type 1 diabetes is an autoimmune disease. The cells in the pancreas that make insulin are being attacked. So you factor that in, and we can start to think about really a program where we identify people who are at very high risk for progressing to type 1 diabetes and then intervening before they actually get type 1 diabetes. So a great example, I think, of the theme tonight, using genomics and other omics to enhance prevention to actually prevent this very serious disease from ever happening in the first place. And I'll just say one more thing, that there's an antibody that's on the market. But of course, Penn is the place where CAR T was developed, and now there are active efforts to go a step further and develop CAR T cells that target that specific target as a way to try to prevent type 1 diabetes. Really a cool way of bringing a lot of these strands together. And that leads me really to a couple final comments. We've talked a lot about genetics and assessment of risk, but ultimately that assessment of risk then needs to be tied to interventions, interceptions, ways to actually prevent the disease. And I think it's fair to say, and our next speaker, Dr. Epstein, may embellish this, Penn really is the leader in developing these novel transformational therapeutics that not only treat disease, but now are in a mode of really trying to prevent disease in a way that I think is truly transformational. And then the final thing I have to say is, it's been a very challenging week and a half for those of us in academic biomedicine. And we don't know what the future holds. But I think it's clearer than ever to me and my colleagues that the philanthropic support for these amazing ideas that we want to continue to do is just becoming more important than ever. And so we want to thank you for your support and for coming out tonight. And with that, I'd like to turn things over to Dr. Epstein, Interim Dean and Senior Vice President for the Health System, and I think he's going to make a few words. John?
Dan and all of our panelists, I just want to thank you very, very much. It was a fantastic discussion. I'll just make one or two very brief points. Listening to all the comments that you've made, I'm struck by how rapidly this field is moving. When I think about, now this is a long time ago, but when I trained, there were one or two genetic diseases that we knew how to diagnose. Sickle cell disease, neurofibromatosis came on board. And even in the last 5 years, understanding the genetic diagnoses has leapfrogged forward. So there are many reasons not to come downtown and face the traffic, but there are some very good reasons to come to a place like Penn Medicine. And one of them is to get a real understanding and answer to questions about what your genetic variants might actually mean. This was underscored for me this week when a gentleman with the means to access the very best healthcare anywhere in the world, and who does have some of the best healthcare anywhere in the world, called me somewhat in a panic because of one of these common genetic testings that you can send out for that his wife had paid for. And it came back with what appeared to be evidence of a risk for pancreatic cancer. And you can imagine the consternation, and you see this commonly. And I connected him with our best genetic counselors and folks with genetic information, and they answered their questions within minutes on a Zoom call. And he wrote me back, why didn't I come to Penn Medicine sooner? So I really want to underscore that when science moves quickly and medicine moves quickly, you need to get the very best evidence, the very best doctors, the people who know what the latest is. And that's what all of these folks up here represent. Finally, I'll leave us and get some drinks and food. Say there are two things I'll remember from tonight. One is that Kiran Musunuru, who didn't make it, who is an absolute phenom and a total star in curing, I think he's going to cure kids with these genetic disorders. He can't, even Kiran can't seem to correct Amtrak. And the other thing I'm going to remember is that ovarian cancer starts in Eddie Lee's fingertips. So once again, an applause for our panel and for our moderator. And I know that they'll all stick around and be happy to answer more questions as we enjoy some food and beverages. Thanks to all of you for coming tonight.